Okay, so let's call this meeting to order. We like to start punctually whenever possible. So I just want to announce that this is a special meeting of the El Dorado Hills Community Council meeting. This is our third forum on mental health, mental illness, and the services available. That's what we're trying to cover in a broad spectrum. And so with that, I'm going to dispense of the leadership team roll call because I know we have Chief Lilly here and we have Cindy and myself, and that's it for our leadership team. So I think since this is a special meeting, we don't need to go through that in any great detail. And we'll move on to adoption of the regular meeting agenda. Do either of you have any comments, suggested changes to our agenda? Okay. Seeing none, we'll move on to item 3, which is just kind of my introductory remarks. So as you may recall, we've had 2 forums before this. And we had various guest speakers to talk about what were the needs to deal with the current mental illness issues and with a particular emphasis on youth and what's going on with teenagers. We've seen stuff from Oak Ridge High School, for instance, that reflects the fact that the suicide rates are going up in a lot of places, not necessarily just Oak Ridge, but there are needs for counseling at the schools, which has been implemented. And we do have the Youth Commission that has made a mental health their project for the last, I think, 3 years now, and have done a lot of things in the various high schools in the El Dorado Union High School District, including Oak Ridge. And so we've had presenters on that. But we kind of started by focusing on what are the needs, what are the specialty needs we have within the county. And then we're kind of moving in the latter phases here towards what are the services that are available or projected to be available in the near future that will help meet those needs. And I'll just give you an example of that. One of the earlier discussions we had Dr. Martin Entwistle involved, and he is with Marshall Medical. And he also happens to be the county's lead for our homeless operations, given the fact that he ran the Operation Room Key project with the county and staff and volunteers and various nonprofits got involved with that thing, the faith-based groups, et cetera. But Dr. Entwistle has had a lot of involvement with looking at community needs and trying to make sure Marshall is as prepared as they can be to handle those needs. One of the things that got discussed was the need to bring in a specialized type program that had been demonstrated at Sutter down in Sacramento. And we were hoping to bring that to Marshall, and that got started with some discussions. And then I guess we got into the point where it sounds like there are some proprietary issues with that since they don't have any kind of a direct alliance between Sutter and Marshall. So maybe that will evolve, maybe it won't. But for the time being anyway, we can't interact with them, which just kind of slows down the process. It doesn't mean that Dr. Entwistle has stopped looking at that need and what he can do at Marshall. It just means using best practices from Sutter may be more difficult than we originally anticipated. So given that consideration, but that's that kind of situation where a need was talked about. And actually it was Sophie, one of our youth in El Dorado Hills here, talking about her experiences and some of the needs she had for mental health services that weren't available in El Dorado County. She had to go to Sutter, Sacramento County to get those services. Huge success from everything I've been able to determine. So that was what we were trying to do, is emulate best practices from somewhere else and bring them to our county to the extent we can without the county directly getting involved, right? Because we have limited resources of what we can do. Marshall is a great partner. Barton Hospital is a great partner up in South Lake Tahoe. So we've made some really good strides in that. But tonight's focus is more on services that are available. What are the centers that we have available to deal with mental health, excluding the services we know that are available in the high schools and stuff. So we have 3 special presentations in kind of the services area. Kyle Nelson is here with us this evening, and he's going to be talking about the Shingle Springs Health and Wellness Center and the types of services they have available. And I'll just remind everybody, even though that is on tribe property and it's associated with the casino and stuff, it is a public facility. And the county actually contributes, partners, if you will, with the tribe to make those services available. So anyone in the community that needs their general services, including mental health, have access to that. So Kyle, and I'm not sure if Joshina is going to make it or not, but Okay, all right. So I guess Kyle will be making the presentation. We want to give Joshina recognition as well. So they will do some self-introductions and then talk about the services they have available. Then we have Terry Stratton, the Executive Director, and Kevin Caskey, who's the Director of Behavioral Health Care and Said Treatment, to represent the El Dorado Community Health Center. And that's the new facility that's being built off of Missouri Flat Road. They're hoping to have that up and operating before the end of the year, which is when Terry is scheduling her retirement, I guess. So that's a win from the standpoint that's many, many years in the planning, and they had various facilities in various places trying to fulfill the needs. A lot of it was rental space, and now they're able to congregate all of that, all those resources within one brand new facility, which ought to be fantastic. So again, those services are available to the community. And in both cases, between what the Community Health Center offers and what the Shingle Springs Health and Wellness Center offers, there are sometimes requirements relative to what your income is, what your insurance is. So there are eligibility things that you have to go through. But most of the people that I know of are able either to get professional help through their insurance company or an alternate source, or use one of those facilities. And then we have Nicole Abrahimi Nuikin with us also, which is with El Dorado County Behavioral Health. She's the director of that organization. And she's going to give us an update since she presented, I think, at the first forum.
Yep.
And we've had quite a bit of time, 9 months or something between the first and this one, 7 months, something like that, to give you an update on the things that she's been able to put into place, and mobilization of some things that were talked about before, but now we've gotten the funding. We seem to be getting a lot more funding from the state now for mental health, with the recognition that there's a severe problem post-COVID. COVID affected a lot of people to a huge degree. And so the state funding seems to be much more readily available to put in programs. And so Nicole will give us an update on the programs at the county and what we're doing there. And then the last presentation is Frank Porter and Diane Romanowitz, who have kind of a unique aspect of mental health facilities called a clubhouse. And I think you'll enjoy their presentation. So it's not a organizational today provided service. It's a vision for the future and what can be in El Dorado County, similar to what other clubhouses are throughout the state and actually international. So they give you some insight on that. I've had the privilege of being involved with some of those discussions, and a great opportunity if we can capture that, because it's another way of helping those people who have mental illness to feel respected, to feel valued, to be able to interact with one another, to socialize, to do those things that we all want to do without the stigma, right? Without the stigma of walking into a public place and thinking I better not say something because somebody's going to be challenging me and all those kinds of things. So it's a warm, inviting environment where there's a lot of camaraderie as well as some opportunities to learn. So I'm going to let them explain the details of that, but I think it's an exciting program. And if we can get that going in El Dorado County, and there's a dedicated team to do it, I think the only question is when, right? And how do we all participate in the funding of it? Because that's the other thing that needs to be discussed. So that's kind of the agenda tonight. And then we'll do some final Q&A and wrap-ups. But we will take questions after each of the presenters so that you get a chance to pose your question, make your comment, whatever. They can respond. And then at the end, we'll kind of do an overall for, oh, I forgot, or I want to go back and talk about this a little bit more. But that's kind of the sequence we have planned for this evening. So any questions on any of that? Excellent. I must have been effective in my communication somehow, or they're just tired of listening to me talk, right? So, all right, so with that, I'm going to move on to item 4. Kyle Nelson is here with us, and I think he has a PowerPoint presentation to share with us and to describe their services and what they're doing with respect to their overall services, but then also specializing in the mental health area, wellness area. So Kyle, over to you, and do a self-introduction if you would. Give us a little bit about your background so we know a little bit about more your history in El Dorado County and what you've been working on.
Thank you for inviting me. My voice is a little off, but satisfaction.
Have you got the microphone going for you? Is it green?
It's green. Yeah.
Okay, good.
Okay.
I just want to make sure we're broadcasting. Good.
Okay, my name is Kyle Nelson. I'm the executive director of the Shingle Springs Health and Wellness Center. I am an enrolled member of the Karuk tribe out of Northern California. Grew up in far rural Northern California, Trinity County, in Siskiyou County. Went to school in the Bay Area. Never really lived south of Sacramento. In Northern California my whole life. Hope to never leave Northern California. And
Oh, we can't hear you.
Better?
Can you hear him now?
I can hear you, John. I can't hear the speaker.
How about now?
Maybe that microphone isn't working. Let me give you the microphone that I think is working. Maybe you've got one with a bad battery or something or other. Something works better.
Test, test, test.
Still not working?
Okay.
I can hear you shouting.
How about now?
Okay, good enough. Kind of. Thank you.
Okay, I'll do my best.
Thank you.
So I moved here for the executive director position about 3 years ago. I've been new to the county. I've been, my kids go to school here. I enjoy working for the Shingle Springs Band and Miwok Indians very much. And thank you for starting out with kind of a description of our services, because that does tend to be a misconception, and we still get that, you know, been in operation since 1995 and still get that question every now and then. Do you serve anybody? Do you have to be Native American to go there? And so, so I appreciate that. I'd like to just start, if I may, with just a 1-minute video that we did, our marketing department did for social media. Where did that sound? Maybe we don't have sound.
Your laptop got the sound turned on. It should broadcast, I would think.
That one thing, I'll take a second. Sure. See if the laptop will.
So you got to join the audio option.
Maybe I can just play it out of the box.
Okay.
It doesn't do it.
Welcome to the Shingle Springs Health and Wellness Center. We are a tribal health clinic owned and operated by the Shingle Springs Band of Miwok Indians. Our mission at the Shingle Springs Health and Wellness Center is reflected in our ongoing commitment to provide comprehensive and trusted health care to any in Placerville and the surrounding community. Shingle Springs Health and Wellness Center, providing personalized care of the highest quality.
I really like that. I'm on mute. Right. There we go. So I like the way that the video incorporates the culture of the tribe, talks about how it is owned and operated by Shingle Springs Band of Miwok Indians, and just I just want to say a little bit about the days for health services that I can do in that. We are not licensed with the state. We have a contract with the Federal Indian Health Service based on the Indian self-determination. And that means that we worked you know, on a lot of the initiatives that are coming out, we're not reporting to the state, we're reporting to the federal government. Our COVID vaccines come from the federal government. And it allows us to be able to operate as a community health clinic based on that contract. And so the legal basis is a list of legal bases for it, including the United States Constitution and several different acts, laws, and Supreme Court decisions. So we differ a little bit as a community health clinic in that we're not a nonprofit and we're not a typical FQHC, but we operate as one department of the tribal government. And so like the county, we're one department of a government system that has fire, police, health and human services. And so that's what our basic structure is and the basis for us being able to provide services for American Indian Alaska Natives. But as you mentioned, in addition, the clinic exists on the Shingle Springs Rancheria to provide access to the tribal members and also as a way to serve the entire community. And the community is not just American Indian Alaska Natives, but everybody within the county. Our service area registered with the federal government is El Dorado County, although we do see some people come from out of county to go to our clinic. And just to overview, these are our departments. We have medical, dental, behavioral health. There's a pharmacy there and clinic administration. We're here to talk about mental health, behavioral health department. This is what our services look like currently. We have a full-time psychiatrist, a psych-certified nurse practitioner, SUD counselor, therapist, and we just started within the past year or so medication-assisted treatment for opioid use disorder. Thanks to all of our wonderful community partners helping us, Dorado Community Health and Chapa Day. And then we have two grant projects. One is SAMHSA grant, Tribal Opioid Response Grant. And then the other is the Circles of Care. Joshina is not here to describe Circles of Care, but it is a planning grant so that we can develop a system of care for our community and our patients that is designed by our community for our community. So they're doing 3 years of outreach and getting community feedback. And then based on that community feedback, they're going to design a system of care that we'll be looking to implement after the 3 years is over.
So could you describe the SUD just a little bit, the substance use disorder, what basic services you provide? Because I know pretty much what the county provides. I'm just wondering if they're parallel, slightly different.
Brand new for us, and we were able to bring on an SUD counselor finally based on this Tribal Opioid Response Grant. Her main focus right now is in the MAT services and is also available to the outpatient primary care team. So if there's any substance use disorder identified in the primary care environment, then they can do the referral there.
Okay.
But again, we're just getting started with that though. And that's one of the areas where we're willing and able to expand as the need increases. So I would say all of our direct services are available to everyone. We accept all different types of insurance, private insurance, Medi-Cal managed care, Medicare, and have a sliding fee discount as well. There are some programs because of our contract with the Indian Health Service that allows us to provide some additional support to American Indian Alaska Natives. And that is American Indian Alaska Natives who are, they meet the criteria set by the federal government in order to be registered in our clinic as American Indian Alaska Natives. So what that means is a member of a federally recognized tribe, descendant from a member of a federally recognized tribe, or a descendant of a California Indian who was registered on the original judgment rolls. There are a lot of different types of documentation that can go into that, but Basically, even if you're not enrolled in a tribe or if it's not a federally recognized tribe, California Indian, if you can show, have some documentation, maybe you have land held in trust from a grandparent, well, then that allows us to enroll somebody or register someone as American Indian Alaska Native. And the programs that we have that are specific to American Indian Alaska Natives, one is purchase and referred care, so that American Indian person in our clinic, if we refer them to services, we have a pool of money that will pay for those referred services. Direct care, anything that's done in our clinic is direct care. So if American Indian Alaska Native comes to our clinic, they have insurance, we'll bill their insurance. Anything out of pocket, there's not going to be any patient share responsibility. If they don't have insurance, there's not going to be any patient share responsibility. So direct care patients who live in our county are, they qualify for the purchase and referred care program. So me and my family, my kids, because we live in El Dorado County, when we go to our clinic, if we get referred to a specialist or have to go to the ER, then this pool of PRC, purchase referred care dollars, will pay for that for us. And then we have some ability to refer to Indian Health Service specialty services. And you'd mentioned SUD services, and especially, I think this comes into play when we're looking into referring to residential treatment. There is a variety, there's probably 4 or 5 adult residential treatment centers that are IHS funded in California. Then we can refer to those that would be at no cost to the patient. And I'll just show you maybe just 2 or 3 minutes of this one if it loads. This is brand new, and this is IHS operated facilities here in California that we also have access to. And I'm going to try turning my volume up again.
The California Indian Health Service is proud to have partnered with the Tribes of California to construct and operate 2 youth regional treatment centers. The services provided at the YRTCs for mental, social, and spiritual health of American Indians and Alaska Natives. The youth regional treatment centers treat male and female youth ages 12 to use disorders and co-occurring behavioral health disorders. Desert Sage Youth Wellness Center is located in Hemet, California. Sacred Oaks Healing Center is located in Davis, California. Each facility has 32 beds, a school, a recreational spaces. Both facilities have highly trained medical, clinical, and support staff. Typically, youth complete treatment in 4 months. However, some finish, while others take more time to heal. Each youth has their own therapist with whom they develop their own individualized treatment plan. Additionally, there is 24-hour nursing care available. Youth also have access to primary care and dental care during their stay. While at the YRTCs, each youth participates in activities of daily living, such as personal grooming, washing their clothes, housekeeping. These activities are designed to prepare the youth for life beyond treatment. Each facility has a library, classroom, and teacher on site to provide education for the youth during their stay.
This is excuse me. Yeah, the one in Davis just barely opened up. I don't even know if they have very many residents yet. I know they're not full and they have availability. So it is, because it's an Indian Health Service facility, they're limited to serving what we call direct care. We serve direct care people and everybody else. An Indian Health Service facility is going to serve direct care. And so if we have a direct care patient, we can refer to them and they'll already have all their documentation that they would need to get admitted to the treatment center.
So that would be a referral from your SUDS group probably to the Indian
Yes.
Healthcare Facility, and so they're both coming up together, it sounds like.
Yeah.
Okay, great.
And then last thing I would show is we just finished upward retreat where they had worked on mission and vision statements. It's the first one that they've had in several years since I've been there. And I just want to, I guess, highlight the, in hearing you talk and looking at what resources are available within the community, their vision statement, El Dorado County, but also, cutting edge health and spiritual healing services. Our dental department, for example, they love technology. They always want the latest stuff with 3D printing and scanning. And I wanted to highlight the last sentence, while growing along with the needs of the community. And so that's where the board and the clinic really is right now, is they're ready to invest in the community and looking at what the community needs are. So what we learned from conversations like these and community partners in the county and El Dorado Community Health and all of the hospital systems and the managed care organizations, if we see that there is a gap in services or additional need that we're able to fill, we're willing and able to start moving in that direction.
Very good, thank you, Kyle. So questions for Kyle or comments, anyone? I'm gonna ask the question I would thought Diane would ask, but for patients who have schizophrenia, do you make that a specialty area of study? Because there are obviously special needs and there's a lot of information known about schizophrenia. But do you have those kinds of expertise available, or that would be a referral, or how do you deal with those kinds of patients?
We do have a full-time staff psychiatrist. We have a full-time psych-certified nurse practitioner and a psychiatrist. And so the level of need that they may, I don't know where they might refer to other than psych inpatient.
Okay.
But for outpatient services, I do know that they are able to cover a wide variety of different diagnoses and conditions. And we are also open to referrals from outside agencies at this time.
Let me ask the other question. Are you familiar with the clubhouse concept? Have you heard of that?
Maybe.
Okay, Clubhouse International.
Maybe they're different names.
Okay, so the last presentation will give you a little bit more exposure to that, because I'm always looking at partnerships, right? Where do people have resources and a desire to help one another, and how do we bring them together? Because that may be some kind of a partnership in the future. Who knows what it may evolve to, but I'll just put that out there as a thought pattern, and we'll see where it goes. So, yes, Trudy.
Right now, we're working with that. That's one of our biggest challenges, and I think that is going to fall across everywhere. Right now, we're working with the community advisory board to identify exactly what it is. I know there's a council. There's a dance arbor on the ground. There are people out there, spiritual healers, dance leaders, and people who, even if they're not, or don't identify as medical people or spiritual leaders, carry a lot of knowledge.
How can you put the microphone up? I'm wondering if
They carry a lot of that knowledge. And so we're looking at ways to connect these types of services. So right now, I would say that we have people who are working within the tribe who are able to connect people. If it's somebody who says, I'm more interested in looking I'm interested in exploring native spirituality. Then we would look at referrals within the tribal system. That's hard though. And identifying those people and finding the individuals who carry that trust within the community.
Any other questions or comments for Kyle? All right, I want to thank you for the presentation. That was very helpful, very informative, and hopefully we'll find a way to partner on some of these things or work together or do referrals or whatever, because the more people are involved in terms of trying to find out what is the right level of care for people, the better results we'll get. So, yeah, Diane?
How impacted is
Our access to care for psychiatric patients right now is pretty.
And some of those patients might be in that care for 6 months or longer, or? Okay, all right.
We have the individual outpatient. Idea and opportunity. Talk to you more about what that looks like.
Okay, we have a Zoom participant, Dr. Clavier, who would like to make a comment or ask a question. So, Steve, please open up your microphone.
I just did. Can you hear me?
Yes, you're coming through fine.
Great, thank you. I just had a very brief question to Kyle. Kyle, did you say earlier that you have the capability of accepting a Medicare?
Yes, Medi-Cal managed care, Medicare, and all the major private insurances.
All right, I just wanted to confirm that because that's something that's not typically available in the county here. So that's important. Thank you.
You're welcome.
Good. All right, we don't have any more Zoom questions. Last call, anybody here have a question or comment for Kyle? Again, I want to thank you for your time and your presentation. I think this is helpful, and we'll try to make sure this information gets spread because we have a lot more followers in our email stream, and we do minutes, and we'll include your material there. And oftentimes we'll get inquiries after the fact. Hey, tell me who I need to talk to, blah, blah, blah. So that's always, the outreach part of this is trying to make sure you connect with as many people as you can. A lot of people don't want to take the time to come to a meeting. So hopefully we'll be able to get you in touch with people who are looking for services and kind of get that started to a greater extent than what you've already got going. But thank you again for the time and the presentation materials.
So
So.
Steve has his hand up again.
Oh, Steve, you got another question?
Yeah, well, just one more thing. It's just a comment. I wish I could be there tonight. I'm stuck home with COVID, so I can't. But the bottom line is, just a suggestion, is with the remote microphone, the only way you can hear it is if he literally holds it up to his mouth. If it's on the table, you can almost not hear him at all. So if the various presenters with those remote mics, if they could hold it right up to their mouth, I would appreciate it. Thank you.
All right, thank you for that. Yeah, because we can't tell what's being broadcast, obviously, in terms of volume. So
Right.
Thanks for that. All right, so I think we're ready to move on to the second presentation.
Have
And
them come up and give them
pardon?
their, have Terry,
yeah,
have them come up and give them
Yeah.
their microphones.
you can come up here if you'd like. It's probably actually a little bit preferable because I was noticing the camera, we should probably turn the camera around so people can see Kyle sitting there. But if you're up here, the camera normally faces this direction, but it's reversible. So welcome. Thank you, John. Good to see you, Terry. Yeah. Kevin, pleasure to meet you. I think we've met before. Yeah.
Yes.
Thank you, John, for the invitation.
And people wanted to talk about when your ribbon cutting is going to be and how they get tours and all that.
Absolutely, and I have a picture in there from
Perfect.
yesterday, so.
Got it covered. All right. Thank you.
I'm Terry Stratton. the executive director of the El Dorado Community Health Center. And can you all hear me? I was a soccer mom at one point in my life, and I did learn to project, so I've retained that skill. So I'm the executive director of the El Dorado Community Health Center, and I've been in Sacramento region since about 1980 and have lived in Shingle Springs for the last 14 years. I worked for the county at one point in my career, and been in this position almost 9 years. And the countdown is on.
There you go.
Okay, I want to give you a little bit of an overview, and I'm going to let Kevin Caskey introduce himself. He is our Director of Behavioral Health and Substance Use Disorder Services, and he's going to give a little bit more detail on what we do. I'll let you advance that. Sorry. Okay, so you will find that we have some similarities to our colleague, Kyle, and the organization there, as well as some differences. So we are also a federally qualified health center out of a little bit of a different arm, and we are under HRSA. So at the federal level, we opened in 2003, and it was kind of a joint urging by the county and Marshall Hospital to really establish what would be termed as a safety net organization for those people in the county who either had Medi-Cal and couldn't find services or did not have health insurance and were showing up at the hospital at the emergency department without any, consistency in care. So we have 5 sites right now, and they are on Golden Center Drive in Placerville, in Diamond Springs, and we have kind of a campus in Cameron Park. And as you know, as John mentioned, we are building a new site, and I'm going to mention that in a little bit more. We have about 11,000 patients and have an annual visit of about 65,000 visits. We have a staff of 150, and you can see the variations of them, and we also have a full-time psychiatrist. And I will tell you, they are like gold, are they not, Kyle? We've had her for about 3 years, and we were like extremely happy to get her. And all the other folks, the psychologists, LCSWs, and Kevin's going to talk a little bit about a newer program that we've launched about a year ago. The next slide, please. So we are very much focused on primary care, and we also will see anyone regardless of what insurance they have or don't have. And so that's Medi-Cal, Medicare, any kind of commercial insurance, and we offer a sliding fee. So if you do not have insurance, then you can take advantage of a sliding fee. And we believe that having insurance or not, or cost, should never be a barrier to care. And we have, for the last, I'm going to say about a year and a half, had a relationship with Kaiser. So we will also take Kaiser patients here in the county. So we do telemedicine, and that has been really spurred by COVID. And I'm going to say about 25% of all of our visits are telemedicine. So it's using all of our technology to have a face-to-face virtual visit with one of our providers. So we do offer that. We have podiatry, dental, pharmacy, health education. E-consults is a way for us as a primary care to take advantage of specialists that can contribute helpful information to our general practice providers through an e-consult with a neurologist, a nephrologist, endocrinologist, a cardiologist. So specialty providers to help our providers better manage the more advanced care that one of our patients needs. behavioral health. In our new site, we will have optometry. And then we have been doing medication-assisted treatment and substance use disorder, which we call STEPS, about 4, 5 years now. I think 4 or 5 years. Yeah, yeah. And so we do have a fair amount, and unfortunately, we have more patients and more need than exceeds our opportunity to see all patients. So for the tribe to, expand into that area is wonderful. Marshall has expanded into that area, and we've urged them to do that and work collaboratively with that, as well as Barton Hospital. So with all of us up and running, we have a better opportunity to try to reach those acute needs. And then we do patient services. Some of our folks have needs such as food insecurity or housing issues or, related things that impact their health. So we do provide that as well. Next slide, please. Okay, I did want to, this is an opportunity for us to really collaborate with our partners, and we believe very strongly in that. And we have some history of doing that, certainly. So one of the things that we do is we partner with the County Office of Education. They own a dental van. We operate out of that dental van, and it goes around to schools all around the county, including up to South Lake Tahoe. That's been an awesome way to catch kids and their dental issues early on. And you would be surprised how advanced some of those issues can get even in an elementary age child. We were very grateful to get some financial support from the county, and we are purchasing a medical van. We hope to have it by, I've seen pictures of it, in December, and want to really turn that into a way to collaborate, whether it be with the schools or homeless organizations or the libraries or wherever. It'll give us an opportunity to go out in the community where those needs are. Kevin may talk a little bit more about the Bridge program, but that's with Marshall Medical and what they have been seeing. They started that about 2 or 3 years ago. They get folks who are in withdrawal who show up at the emergency department. So as opposed to keeping them for a while and sending them out and they just return, there is a bridge or a handoff to what started with us, and now they have the capacity themselves, and Kyle may be able to take some of that on too, to where we make a guarantee that we're going to see those folks within 24 hours. They start them on something called Suboxone, and then we start moving them towards that new life that they can achieve through the medication-assisted treatment program. County mental health, I appreciate that question earlier about schizophrenia. We treat this is some state rules, we treat mild to moderate behavioral health. The county gets the severe. Now, the challenge there is that we do have people that vacillate back and forth, could be day to day, week to week, hard to tell. But we get some of yours and have to deal with them sometimes, and certainly have a very collaborative relationship there. Also work with law enforcement, social services, churches, and other nonprofits, and we are a nonprofit, a 501c3. Next. Okay, I took that picture yesterday. You can see the clouds in the back. Yeah. We have a camera on it. I went by today, and John, if my eyes look a little like peaked, that's because we are planning on opening in less than a month.
Wow.
So the urgency is on, and we are really excited about our new site. Our site on Golden Center and Diamond Springs are leased facilities. We have totally maxed out the space there and have not been able to expand services. So we purchased the 12 acres on Missouri Flat. It's just south of Highway 50 about 3 years ago and have been working to build this new facility. It's 30,000 square feet. We will have all the services that I mentioned before, plus optometry. And I'm almost afraid to say it, but our planned opening date is October the 12th.
Right now.
And it's going to be a soft opening, so expect an invitation to the formal opening,
Okay.
which will likely be in early November. So we're excited about having everything in one space, and we've had a lot of contributions to this effort. We got a USDA loan for 37 years at 2.125%. You know, our CFO and I said, wow, people in the future are going to say, man, what an awesome loan you got.
Exactly. Well, our sheriff's public safety facility.
Similar
same
kind of thing.
Great
Awesome.
interest rate, 40-year term. I mean, it's like, you can't beat this,
You
right?
cannot.
So,
We got a $1 million grant from HRSA to put solar and generator and solar battery. And we had to do some mitigation in the front to have, in case we have rain or anything. So there's a little depression pond in the front. So we've had some other grants that have really helped us with this process, and we're really grateful for all of our partnership and look forward to opening that. So, can we go on to the next slide? Thank you. Kevin, I'm going to turn it over to you.
Thank you, Terry. So again, my name's Kevin Caskey. I am the Director of Behavioral Health and Sub-Treatment Services at the Community Health Center. I've been in the area for 4 years. I moved out here from Nashville, Middle Tennessee area. So in addition to my role as director, I'm also an LCSW, so I still see patients, practice a couple of days out of the week. So I'm going to talk about our department and specific programs within our department. You can go on the next slide, please. Thank you. So within our department, we have really three areas that I'm going to highlight. We do have behavioral health, which is your longer term psychotherapy for patients. That can last anywhere from, typically that's going to go on for a few months, and depending on presenting issue, I mean, that can go on for a couple of years if you're talking about trauma or some deeper issues where longer term work is required. We're staffed with LCSWs and currently one psychologist, but we've had other psychologists in the past, and certainly continue to recruit for that particular type of discipline. We treat everything from depression and anxiety or adjustment disorder all the way to post-traumatic stress disorder. So there are a variety of presenting issues that we'll address. Again, we do remain in the mild to moderate category. We're not really, as an outpatient clinic, equipped to do anything in the severe category. It's not to say we wouldn't help someone who's in the maintenance phase or something like that. But if we're talking about a very acute situation that requires a high level of case management, that just wouldn't be appropriate for our level of care. We also have, and this, as Terry mentioned, we have a new component to this department, our IBH, or Integrated Behavioral Health program. That started, it informally started in 2020 with some funding, but that wasn't a good year for anybody with COVID. So it really came into fruition in 2021. And what that particular program consists of are, we have what we call IBHCs, or Integrated Behavioral Health Clinicians. And they are ACSWs or AMFTs. And I know there's a lot of acronyms in our field. So that's Associate Clinical Social Worker and Associate Marriage and Family Therapist. And those are individuals who they're licensed, but they're not independently licensed, for those of you who aren't familiar with the acronyms. And they're working towards independent licensure. So they have a clinical supervisor who's on staff with us that oversees and supervises all their clinical work. Now, their scope consists of short-term work, crisis intervention. We have them embedded within our primary care operation. So say, for instance, a patient were to show up and they're seeing, their provider, their medical doctor, and they're reporting symptoms of suicidal ideation, and it's a risky situation. We have these clinicians available for a warm handoff where they can assess, on the spot. And, oftentimes, if they can stabilize the patient, safety plan in these situations, and feel reasonably, confident, obviously, with, a lot of safeguards in place that they're stable enough, they'll refer to us, long-term for behavioral health, but they'll continue to monitor the patient until they get seen by, one of our long-term clinicians. Or if it's a situation where it's, we can't really assure safety, then obviously we refer immediately to the emergency room. There's also an element of case management that these individuals, these providers do. So, if there are issues with housing or, food or any other types of basic resource, they can assist with that. They may oftentimes refer on to patient services. So linkage would be an element of what they do, and it's that can sometimes extend to the county as well. So they do an element of short-term work. So you might have someone with a presenting issue that can be resolved in 6 to 8 sessions, and they'll do that as well. But typically, again, it's focused on short-term interventions, crisis stabilization, and referral to some other type of service, either internal or external. We can move on to the next slide, please. Third piece of our department is the STEPS program. STEPS stands for Supportive Treatment Empowering Personal Success. We used to be known as the Complex Care Clinic, and I believe it was 2019 we rebranded, just came up with a name that we thought spoke to the spirit of our program. And it started, it started in 2016 as the Complex Care Clinic. You can move on to the next slide. And it really started as, we're at the end, sorry, I thought we had some, that's all right, I can talk through steps and tell you about it. But we started really focusing primarily on medically assisted treatment for opioid use disorder in our first couple of years. And we were really in the thick of the opioid epidemic at the time, and that's where so much of the focus was on. But as time went on, I mean, obviously, your needs change, your needs diversify, and I think most of us in the field recognize, well, we're in an addiction, epidemic. It's not just opioid use disorder. So really, our first path of diversification came with paying more attention to alcohol use disorder, and we created a track for that specifically for patients with AUD as a standalone diagnosis. Started treating more and more of that. Of course, what we began to encounter, and I'm sure this will make sense to some of you, are those situations that were too severe for us. I mean, we couldn't, obviously, if someone is in a more severe stage of alcohol use disorder, that's not something that's appropriate for us to treat on an outpatient basis. So we had to backtrack a little bit and, develop protocol and develop, obviously a ceiling in terms of what we could address. And that's come along well for us in the past couple of years. I mean, I'd say right now we currently 65% of our patients present with OUD, probably 20% AUD, and then we also have a percentage that are mixed, or what we used to call polysubstance use disorder. And then probably 5% is just standalone stimulant use disorder. Now, a lot of our OUD patients also present with stimulant use disorder on a co-occurring basis. So we do have, we've implemented what's called contingency management in our field, where we may have a patient where we've stabilized OUD, but and it's in remission, but they're still using methamphetamine, for example, on an active basis. And we don't discharge those patients or require them to come off the substance. We'll continue to work with them. And really, we just try to meet them where they're at, as the expression goes. And when I talk about contingency management, what that looks like is just, they show up for a group, and if they're just, actively engaged, we'll give them a small gift card. If they really want to work towards abstinence, we'll, offer a reward for, a urine drug screen that's free of methamphetamine. But you really try to keep that pretty simple, because stimulant use disorder is very, very difficult to treat. I mean, the relapse rate is very high. But switching gears a little bit and going back to the alcohol use disorder, again, we have a specific track for that. We will do outpatient detox, but it's, the protocol for it's pretty strict. We have to be really careful. I mean, one of the medications you'll give, is a benzodiazepine or Librium, which that's just not something we're going to give out, for several days and put the patient at risk of possibly using alcohol at that. So, we'll give them a day's worth. They'll come back. We'll make sure that they're not drinking, give them another day's worth. Some patients don't require that. So, we have like naltrexone and, things to reduce cravings, and gabapentin, which is not as risky as Librium. But we're doing the best we can to, adapt and evolve on an outpatient basis. Obviously, there's a ceiling to what we can offer. The past 6 months, we have implemented the use of something called the ASAM Continuum, which is software that uses ASAM, or the American Society of Addiction Medicine's criteria for assessing level of care that's needed. For those of you who are familiar with drug Medi-Cal, there are counties such as ours that are under that system. They use ASAM to assess for levels of care, so we wanted to try to be uniform. So even though we can't always, get patients to the level of care that's needed just because of the, lack of availability in terms of beds, at least we're talking the same clinical language. So I think that's one area I'm really proud of. I think we've made a lot of strides. We're trying to really promote and develop, best practices, and we all talk the same language, whether, it's at a county level or like us, we're at a community or outpatient level. But some of our challenges currently are really just, like I mentioned, if we have patients who require a residential level of care, in their Medi-Cal, finding a bed for them is really difficult. I mean, we just had a meeting this morning with the county about that, and I think we're all just trying to figure out how to address this at a community level. That's one area where I think we could all, really put our brains together and try to, find common solutions. I've heard, I think we're going to be hearing about, youth. I'm not familiar with the organization, but that's another area where I think, we're needing to evolve and looking at potentially treating youth with use disorders. I mean, we on the behavioral health side, we do see adolescents and children. I mean, we were very lucky to have gotten an LCSW who is Spanish speaking, and she sees children. So we call her the golden unicorn, because you just don't find a lot of people with that are bilingual and have that skill set. But recruitment and retention speaks to another issue and another challenge that we've had. And I see a few heads nodding. So I think that's something, we're all encountering in our field, but particularly for areas like this, more rural areas, it can be challenging to recruit. So, with that, we've tried to, go with really investing in a good solid internship program. So we've had, thanks to Terry and other, other executive leaders. I mean, we've had a lot of support in, building up an internship program. We were very fortunate to get a grant to support that. So we've tried to not only have an internship program, but a workforce development program where we have students come up, intern with us, and, we're looking to, keep them long-term, but not just for our organization, but maybe to get them, familiar with our community and other organizations out there. So that's something else I just really want to promote and mention, is just the importance of having internships and internship programs, because I think that's how we keep, we keep retention up and make our recruiting efforts a little bit easier. Because I know for us, it took us I think we had a couple of positions posted for probably 6 months on the behavioral health side, and we were pretty understaffed. We're still understaffed. I mean, we have a wait list of about 150 right now of patients, just our own patients referred from primary care needing services. And again, I don't think that's a unique issue in our organization. So that's all I have, and certainly any questions I'm happy to address.
Let's open it up for questions, either for Terry or Kevin. So, anybody have a thought at this point or a comment?
I have a question. It used to be years ago that you had people on 60-day rotation, professional staff, and it was very difficult for a patient to establish any kind of relationship with a provider, medical services. Have you been able to fill permanent with long-time staff?
We have, and since I've been at the center, we have not done a rotation. We actually are impaneled, so our providers do get a chance to really get to know their patients and have them long-term. Now, what does happen is sometimes, we have patients whose child has an ear, ache or something like that, and they just want to be seen. So we make sure that they're seen as soon as possible, but it may not be with their primary care provider. It may be with another provider who is scheduled to do same-day appointments that day. But yes, we do. And we are at something called PCMH, and it really looks at patient-centered medical home. And we look at whole person care. So that would be one of the kind of attributes of whole person care, is that consistency in care.
Anyone else?
Your behavioral health department and your disorder, how intertwined are they? Mental health, mental illness, and substance abuse generally are completely intertwined. And program work together. Do you have an actual dual diagnosis kind of a program, or is it still pretty much separate?
It's very much integrated or intertwined. I mean, just from a org chart perspective, I mean, they're housed in one department, so that was a change for us, where the program was housed within primary care, and moved it over to behavioral health to better integrate. Even prior to that, though, we had a dedicated or embedded therapist within the STEPS program, and just for rapid access. But once we merged the departments, we enhanced that. So we have that, we still have that, but we also have really now 2 IVH or integrated clinicians that participate in the morning huddle. That's where the team comes together and discusses the patients that are coming in. So they're available really for immediate or warm handoff to behavioral health services. And both of our providers are, they're not, Dr. Reyna has specific training in psychiatry. He's not a psychiatrist, but he's comfortable with getting patients started on certain medications. And then Dr. Velasquez, she's comfortable in that area as they're also, and I can say this from a provider, behavioral health provider standpoint, they're very, I mean, they understand the value in it, so they're very quick to refer and recognize, you know, a co-occurring issue and can speak, you know, pretty intelligently about it. So both just in terms of, you know, how everyone's trained and how they work together. I mean, it's a team-based model where, again, it's a huddle every morning. So they're really looking to address both those issues. So great question.
Terry, you mentioned something about, when you were talking about mild to moderate, and then you said, well, but it could be somebody who's on maintenance, who's, you know, their state of recovery is maintenance. And then you said something about, well, sometimes you have to go back and forth. Did you say a little bit, were you talking about sending them back?
Uh-huh.
To
Yes.
Could you say a little bit more about that, or maybe something?
I think, and I can just respond to it right away and correct me if you see it differently. I think it really is, again, it's really very nice, I have to say, I really, from my perspective, appreciate that I have the partners here today at the table when I'm presenting about county behavioral health, and we have that mild to moderate behavioral health system right there. Because that's the one thing in California under the Medi-Cal benefit that the state many, many decades ago decided to carve out specialty mental health services. So it separated this mild to moderate mental health world from the specialty mental health services. And so we all know that we are all individuals that don't always perfectly fit into a box. And that's really what Terry was addressing. So yes, we have situations where, let's say we had somebody who has come to us, an adult presenting with very severe mental illness, very high level needs. And through treatment, through medication, we found over time, and that could be years, that could be months, whatever that individual needs, has demonstrated stabilization, has demonstrated being able to function in home environment, engage in the community. So we reach out and we say, this is really somebody who's stable with the medication. We really think this is somebody who could transition into the mild to moderate. People change, life circumstances change. That individual 6 months down the road may encounter something where things just really unravel. And Terry and her team, Kevin, will contact us back and say, you know what, we really need you guys again at the table. So that's the situation. We hope to be able to have these length of times, right? Because we know it's difficult on our systems, it's difficult on the individual, but you know, it's life circumstances that we do our best to work and make it transitions as smooth as we can.
Just real quick, if a parent has a child that, or an adult that is in a crisis, how do they know who to call?
Crisis line. All the crisis line.
I don't know if you've got a copy of
Look
this
at you,
yet,
I
but
do. Yeah.
We're gonna be covering that in more detail.
Okay.
We'll talk, so I think you may get more
That's all the
responsive
crisis.
answer there, but that's a pretty comprehensive thing. But yeah, crisis
So you'll
line.
market this to, or publicize this, or get this out?
All those numbers and resources aren't on our website. I will
Oh.
say that our county website, we're actually launching something where we're hoping to improve it. But I think this might be a very useful flyer right now for all of you to just take home and take extra ones and share with your friends.
Very good. Yeah, Robin.
Are we talking about mental health or substance use? Because remember, unfortunately, in our world, we also are very separated when it comes to substance use and mental health. That is
Well,
not,
both.
not completely true for mental health. And I can say it now, and then I'll kind of make it shorter during my presentation. So we do have a very high level in the county, our psychiatric health facility. That's a locked facility, inpatient mental health facility. And we actually, in our system for county mental health clients who may need, we have what's called a social rehab facility. So that's a lower level of care. It's 24/7. It provides treatment at the facility, but people are also very engaged in our services. 6 beds in that, and the psychiatric health facility has 16 beds. The psychiatric health facility is since it's an inpatient block facility, California law very much requires that you have to continue to be at that risk of danger to self, danger to others, or you're gravely disabled in order to stay. It's intended to be as short as possible. For most individuals, I would say on average, they stay probably a little longer than the initial 3 days. So I would say off the top of my head, I don't have the data right in front of me, around 5 days. But the spectrum is very broad because we have a certain group of individuals, because of their circumstances, they're LPS, Latterman-Petrus Short, conserved individuals. They often will stay at the psychiatric health facility until we have the next placement available for them, even although they no longer meet those criteria. And that's the only ones where we can say, we're going to keep you because the conservator and we are looking at finding that next placement. Social rehab facility, typically probably around 60 days, 90 days.
Is it harder to set up residential facilities than an outpatient? You guys,
Can I add something to that? I think what has changed in our system of care is that as much as we recognize we need all levels of care to be functional and really address the needs of the community, we really are hoping to be able to reduce those residential treatment stays by engaging people in very intensive outpatient services. So the idea is if we have somebody, if we have an environment at home, in the community, whatever that is, where an individual can be, but then engage that individual in our, what we either call intensive case management or full service partnership services. We feel that that has a better likelihood for a good outcome versus having somebody removed from their very specific support system and having them stay in residential. Now, sometimes we need that placement, right? Because that presentation is that way. But I think that may have changed over these last couple of decades is for us, especially in county behavioral health, is to identify and to recognize we want to really know that we need the entire spectrum of level of care, and we want to try as much as possible to support that in the home community with that support network, building those skills and continue to rebuild the recovery and the stabilization. Sure. Yep.
So we have a state license, and it would be very difficult for us to do any, inpatient kind of service.
reason I'm bringing this up is my last position around here. I was a therapist up in Yuba City at a place called Willow Glen. Do you guys know about them? They house, like, people live there for years still. And it's behavioral health, and there's long-term care. I just pulled up their website. And read what they have. They might be, and I did actually contact their CEO about asking him, how are you doing this? Because they serve.
We have sometimes patients at Willow Glen. Willow Glen is one of our contracted facilities. When we, yep. Yeah. Oh, yeah. I actually don't know specifically for them. Yeah, I have. No, it's likely in that number arena. Yeah. We do. We have so we have the whole spectrum is something at the highest level of care is inpatient, locked inpatient facilities, right? And so we are able to use our PUF as much as possible. Sometimes there are certain healthcare restrictions or medical restrictions that the PUF cannot address. So then we need to go to an actual psychiatric hospital placement, which would be outside of our county because we don't have a psychiatric hospital in El Dorado County. I think you're thinking about the crisis residential treatment
Crisis
now. Yeah,
residential, excuse me,
yeah,
crisis
yeah.
residential.
So that's a locked facility. That's the highest level of care. And then we go into, for adults, oftentimes what's called an institution of mental disease, IMD, or mental health rehab center, mental health, MHRC. Those are the next, kind of the step down if needed. And they are very large facilities. The reality of those is, I'll go into a little bit into funding, and because you brought it up, maybe it can be paid for. So insurance, Medi-Cal insurance does not cover those facilities. And so when we need for our individuals that we're serving, county beneficiaries, Medi-Cal beneficiaries that need that placement, we need to use a funding source called realignment. The state gives realignment to county behavioral health divisions. It's a very set amount of funding every year that we cover many, 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 many services. It's not just the one individual who goes into that placement, but we need to cover many, many, many of our services through that. So it's something that we really need to look at in order to be sure. That's where, if we can build for those that are appropriate, locally serve resources like a crisis residential treatment facility. So the crisis residential, in a way, is a parallel high-level facility. It's not a locked facility. So we wouldn't be able or wouldn't want to send somebody into a crisis residential who really needs to be in something like the PUF, the psychiatric health facility, or an inpatient, because there's such a danger to themselves or to somebody else. We really need a locked facility. But oftentimes we may have somebody who's really in crisis, who really wouldn't be stable in their home environment, but who wants to be engaged, who has some ability to say, yeah, I need to be in a good place and a safe place. That's where crisis residential can really play a wonderful role, because it's a facility that we actually can, Medi-Cal will allow us to fund, and we can have somebody stay for 30 days, and then we have to revisit, and then we could extend it if needed under certain circumstances. So you can already see it's a longer term. It allows us to stabilize somebody. And again, we are really looking at, and I'm kind of giving you all my pieces of my presentation right now, we're really hoping in El Dorado County from the Behavioral Health Division to continue further as we look at expanding our adult residential 24/7 type options. We want to bring more into the county, but we also want to strengthen our outpatient treatment services, because we really hope, that's the goal. The goal is really for anybody in El Dorado County, regardless of what intensity of mental illness somebody is struggling with, is to stay in their home community, is to stay in a home, is to stay with some form of a home support system and not have to be in a 24/7 residential treatment unless they really need it. I'm not excluding that, but I'm saying that's where we're really hoping to build stronger outpatient treatment services with very intensive services where we go out to the person and the home and really check in with them, make sure they're okay, make sure they come to our wellness center if they need to be, or maybe even going to the clubhouse if we have a clubhouse in the future to get some more job skills training going so that we can bring that person back into a fruitful life in the community as much as possible. And so that's what we really want to do, because it really, I think in the long term, the MHRC level type facilities are meant for a place when needed for that, still time limited, because we want you to come back into our community. If you're in an MHRC, you're really not going to be engaged in those outpatient treatment services. You wouldn't go to the clubhouse. You wouldn't come to the wellness centers. You're really in the MHRC, which makes sense because there's treatment components. But the goal is to step down, and for us to build that system and that capability. So at this point, MHRC and IMDs are not necessarily something that we are going to focus on. We have them in our neighboring counties. We actually are looking at one right now in Auburn. There's a new MHRC opening in Auburn. So they're really close for that time where a person needs to be in a 24/7 setting. But then we really want people to come back to the community.
Okay, can we refocus on questions?
My comment too is that it does not work without affordable housing. It does not work.
I don't want to get into the Coles discussion more than we have, so any specific questions for Terry or Kevin? Yeah, opportunity.
I don't know
yes.
how they pay for it. Do you know, I mean, they must be Medi-Cal, a lot of the.
Oh, no. So the Willow Glens that you looked at, or the, anything less than MHRC and IMD, and anything that has more than 16 beds, is not a Medi-Cal funded facility. Yeah. Yeah. Yeah.
Definitely worth looking into. How are they doing it, and is that something we could bring to El Dorado County at some point in the future? But, you know, statistics make sense to do that. So. Any final thoughts for either Terry or Kevin? Any questions?
The celebration will likely be that first week in November, but we haven't set on a date yet. Hopefully the weather will hold, and yes, we'll make sure it's an open house. We would love to share it with you. Thank you.
Everybody on Zoom. So thank you again for the
Sure.
time and the presentation. Excellent information. So, yeah, well, I need to follow up on that. It's been kind of a stacked deck lately, but I'm getting a little bit worked off. Great. So with that, we're going to segue into item 6, and Nicole's given us a little bit of insight into what her presentation is all about. But if you please give us a little bit more about your background. You've done it once, but I think a recap would be helpful, and then right through the presentation.
Thank you. Yeah. Nicole Abrahimi-Nukin, Behavioral Health Director here in El Dorado County. I've been with the county and in my position for a little more than 2 years now. Came right at the height of COVID, which was an interesting way to come into a county and into a whole behavioral health division. But am fully invested in my position in hoping to expand our services and build a strong system and a strong partnership with really, really strong partners. I will tell you, just on a side note, that was certainly something I knew about El Dorado County I came from Placer County, residing in Nevada County. I had been in Nevada County as well. The medication-assisted treatment services availabilities in the county are just impressive, on a side note, just really impressive. So I was very excited to be able to come into the county. So let's go to the next slide. So we touched upon this already a little bit, but it's the complicated piece about behavioral health and really both mental health and substance use. But today, let's focus a little bit more on mental health. In how services are being delivered in California and therefore in any county is this piece that I touched upon briefly, which is that the state, the way that it gives the responsibility, created the carve out for the counties to provide those specialty mental health services and for the community providers to provide those mild to moderate behavioral health, mental health treatment services. So that's Medi-Cal population in a county is our big focus, our main mandate for the county behavioral health division to address those needs. That's for both substance use and mental health. We also have, since 2004, the voter Prop 63 Mental Health Service Act was passed by the voters. It was put into action 2005, 2006, depending on when the county was ready to implement it. But that's a special tax that is collected every year at the state level and then distributed to the counties with very specific regulations as to how Mental Health Services Act funding can be used. But as you can hear, mental health, it's really geared towards expanding, improving these services in the community with a very specific community input process for this funding. While the Medi-Cal funding is regulated through my contract with Department of Healthcare Services, the Mental Health Services Act funding, we really do engage the community. And I want to put a little plug in here. We're going to be reaching out to the community next month because we're entering into our very important community input process for our next 3-year plan. Mental Health Services Act funding is always expanded with a 3-year plan. We are in our final year of the current plan, and this fall we want to engage the community in hearing how are you perceiving that we're providing these services? Where are you seeing these gaps so that we can build a strong 3-year plan going forward with the next fiscal year? I mentioned substance use disorder services. We provide those in my division, Behavioral Health Division, which is part of Health and Human Services. We also have the Public Guardian's Office. And then we are, the county behavioral health are the crisis services providers for mental health crises in the county. Let's go with the next slide. I'll just touch on this briefly. Really, the Mental Health Services Act is the funding that we get is divided up. I said it comes with very specific regulations. We can use it to strengthen our prevention and early intervention services. This, by the way, really has come to fruition because of Mental Health Services Act. Prior to that, Medi-Cal doesn't really fund any prevention and early intervention services. So we can really use this fund to address these needs in the community. And that will community needs. That goes beyond the Medi-Cal population. Then we are to use the services, Mental Health Services Act funding to strengthen our community supports, services and supports programs. Those are treatment programs, mental health treatment programs. We have funding to try out an innovation project every 5 years to kind of look at trying something new and innovative and see if it works. We have funding to strengthen our workforce education and training, and we also have funding for capital facilities and technology needs. That's
It's very prescriptive. A certain amount of money is dedicated to each one of these. There's a lot of requirements to it. So it's not like you can take money over here and shift it over here because that's where the greatest need is.
never is like that.
Never works that way with the state operating program.
Nope. Let's go to the
I
next
think it's
slide.
getting better.
We're hoping. There's some discussion around that. So just a snapshot of what our specialty mental health services are. Again, that's both children, youth, and then also adult specific eligibility criteria for our services. But this is an array of services. We provide our run-of-the-mill, for lack of a better word, outpatient treatment services where we maybe see a youth or an adult once a week, once every other week, kind of discuss, somebody earlier mentioned trauma issues that have been experienced. On the other hand, we can go to the full gamut of very intensive services with a lot of case management, rehab support for the individuals. So it's always driven by what the individual needs. Let's go to the next slide. Just briefly, as I mentioned, the division actually also has the public guardian's office. So I oversee, we have the probate conservatorship, the LPS conservatorship. That's the population that frequently then also is served through my behavioral health services. So oftentimes for our LPS conservatees, there's mental health services and maybe even substance use treatment services. And then the guardian's office also has representative payee program. Next slide. Substance use disorder services. Again, this is the Medi-Cal drug medical organized delivery system that was built here in El Dorado County in 2019. With that comes a very much an effort to build a true system of care for substance use treatment services that didn't quite exist prior to the drug medical ODS in the counties. We provide outpatient treatment services. We have a provider for intensive outpatient treatment services. We have residential treatment. We have withdrawal management in residential treatment. We provide case management services when needed and also have recovery support services available. Okay, next slide. Crisis services came up a couple times. So yes, please, if anybody experiences a crisis, please call our crisis line number, our 24/7 number. Right now, somebody mentioned that already. So typically for a crisis individual that's presenting at high risk, you would be assessed at the either Marshall or for South Lake Tahoe at Barton Emergency Department. Our crisis clinicians are partnering in the ED department to assess if somebody really does need to go to an inpatient level of care. We do have a mobile crisis that is a small piece with our sheriff. It's a partnership with our sheriff for 4 days of the week. We're in the sheriff area, so mostly on the western slope, a little bit up towards South Lake Tahoe. A deputy and a clinician would go out if it's appropriate. And again, for those 4 days of the week, so it's not 24/7 at this point. And I'll talk about that at another slide. Where we can go into the community and meet the person out there wherever they are and try to de-escalate. Obviously, the goal here is really to try to de-escalate the situation, connect somebody to services, and avoid having to go to the hospital, having to be evaluated for possible inpatient stay. Next slide. We have wellness centers. So wellness centers are a little bit different than the clubhouse that Diana is going to talk, and Frank is going to talk about a little bit later on. Wellness centers are really geared for predominantly for the population and our adult population. And these are really typically are really severely mentally ill impacted individuals that are in our treatment services. They are engaged in our outpatient, but really still at a level where engaging with a group of people, interacting, processing information is still very overwhelming. So we have a very protective environment where we focus on skill building, but it's really towards building those skills of being able to socially engage with others and identify goals for myself. And so oftentimes the way that I look, I've been involved in, thank you Diane for involving me in that process with the clubhouse. I think I can almost see it as a step up for the clubhouse to be a resource, certainly for the population that we serve. We have a wellness center both here in Diamond Springs in our office and then in South Lake Tahoe office. Okay, let's go to the next slide. So one of the requests was to talk a little bit about what's been happening since last year. I was here last year, I think about November when we had that first kickoff. And one of the things I did want to mention to all of you in the community is that clearly as a community, we are impacted now. I mean, it's been out there on the forefront, but last year we were significantly impacted by the Caldo fire. We are now hopefully at the tail end of the mosquito fire. Luckily, it didn't impact the community in any shape or form as the Caldo fire did. But the Behavioral Health Division, that is a piece that we certainly have as much as HSSA, our Health and Human Services Agency has, is to support the community in these kind of events. Clearly what we need to do in those moments and what we did last year is to look at who of our individuals that we already are serving is impacted. Who is in that arena, who needs to be evacuated, who needs help to be evacuated. So that's the first focus that my team had last year. But then we engaged in all the community support events and going out to the shelter, looking at who was at the shelter beyond our individuals to support these individuals that were impacted. We have continued to be at the table at those Caldo recovery community events. We also, the Board of Supervisors last year approved funding to Health and Human Services as focused to bring 2 positions to our agency, the Health and Human Services Agency, to partner in the Caldo Fire Recovery Project. And we now have a dedicated mental health worker, excuse me, who is part of that group. She has been gung-ho and building support groups. She's now actively running support groups specifically for the Caldo Fire community. So that's not individuals that are part of our system of care, but that have been impacted by the fire. And she has now been very involved in going out to the shelter for the mosquito fire evacuees. Next slide. This is a really big topic and really actually needs its own presentation. And I'm maybe not even so much an expert on it, but I did want to mention it because we talk so much about Medi-Cal here as the insurance that covers much of our services. The state has launched, talked about it, but really launched this year a huge effort of advancing and innovating Medi-Cal with an effort to really look at healthcare, and that is physical healthcare, that is behavior health, both substance use and mental health, needs to be better integrated. I think Terry mentioned whole person care approach. That's really something that the state is looking at, is to trying to identify strategies to improve so that Medi-Cal beneficiaries experience their healthcare, whichever door they walk through, as a whole person care approach. Now, specifically for behavior health, there's a whole lot of changes happening as well. Much of it is still sort of in the flux, so it's hard for me to really pin it down for you. But one of the things that we're hoping to gain through this actually is something that we touched upon, which is in Medi-Cal, as much as we try to do integrated services, and we really approach it as a co-occurring in many situations administratively, I as an administrator, and now Kevin as an administrator needs to look at it, at least on the Medi-Cal funding. My substance use funding is defined very differently than my mental health funding is. I have different reimbursement rates. I have different service codes. I have a treatment plan that needs to be written in substance use, and then it needs to be written in mental health. So you can imagine that that's a hindrance on many levels to really bringing it together from our provider perspective. So CalIM is looking at that and is hoping to integrate us truly in a few years down the road. Some things that have been now being launched driven by our managed care plans. So if you're a Medi-Cal beneficiary in El Dorado County, you can choose if you want to be a Medi-Cal managed care plan beneficiary under Anthem Blue Cross or under California Health and Wellness, or some also have a Kaiser managed care plan. These 3 managed care plans have been tasked with building something that's called Enhanced Care Management, ECM, which is really geared towards bringing individuals that struggle to connect with their behavioral health services, substance use, mental health, to be these navigator case managers. I'm very much watching this. I know both the Community Health Center and the Shingle Springs Wellness Center are partnering also in listening and meeting with the managed care plans to watch how this is being built so that we can really make sure that our community can benefit from it. But I'm excited about it and continue to monitor and hope that this will really support our system of care in El Dorado County. Let's go to the next slide. So now directly behavioral health. So one of the things that we were able to do this year is really look at how to bring additional funding into the community, into behavioral health and some of our partners to help us build that stronger system. And really excited about the partnership with the El Dorado Counties of Education, Office of Education. We were able to be awarded the Mental Health Student Services Act funding that over the next 4 years will give us the $4 million. We are just at the beginning of deciding and developing what that's going to look like, but it's all geared towards strengthening support for mental health in the schools in El Dorado County. So that will be a huge benefit to our students, and hopefully, on some level will address, because that's where prevention and early intervention is so powerful. If we can early on bring these skill sets and support this early on, hopefully we will decrease the pressure on these high level needs later on. So that's where this funding is really going to help us. The Behavioral Health Division partnered with our child welfare partners. That ended just now because there was a decision made to move it over to a contractor, but we addressed the needs specifically for foster youth and previous foster youth with the Family Urgent Response System, which is basically a mobile crisis team that would go out into the community if there was a foster youth or a former foster youth that called a crisis line specifically for this effort. So we were able to do that. We were able to bring an additional mental health block grant funding. That's actually a federal fund. That's not Medi-Cal funding. Into the community to expand our first episode psychosis program. So this addresses the needs for individuals sort of late teenagehood into early adulthood. The first time a psychotic episode is being experienced, and we can hopefully really address and engage early on to prevent, again, that long-term development into a more severe presentation. We obtained the Care Crisis Mobile Unit Grant. So I think I'm going to spend just a little bit more on this, but I know my time is already talked a lot. This is an exciting piece where we were able to draw down a planning grant. Many of you, I think, have become aware that in July, the state rolled out the 988 crisis number. This is a new crisis number and actually a federal effort in all of the states to implement 988, just like 911 has been very successful for people to remember. If I have an emergency, I'll call 911. Crisis numbers have been 7-digit numbers so far. And so we really, or specifically suicide prevention numbers. And so the federal government tasked the states with implementing 988 in the hope that people can remember 988 just so much better in a situation like that. With that, in California, the discussion has started to say, well, that's really good. We're glad we're doing this. Now, what happens if somebody calls that number and they are in Georgetown and experience that crisis? Wouldn't it be better if we can address that crisis right out there, now that we know we have this person on the phone? So that leads into building mobile crisis systems in all of California and all the counties that truly is 24/7. So this planning grant has been hugely beneficial. We've engaged a lot of stakeholders. Supervisor Heidel joined us several times. I think we've now had 9 meetings with stakeholders, really strong input, really appreciative for us to determine. So we have our crisis psychiatric emergency response team that functions 4 days of the week. We actually already have a small collaboration with police department in South Lake Tahoe for a similar type, but it's a small, tiny little piece. So building on what we have and expanding it into a true 24/7 mobile crisis throughout the county. How can we do that? So the planning grant initially gave us the ability to engage the stakeholders and with the task to develop that plan, that model, and submit it to the state. In the process of having this planning grant going on, the state reached out to the participating counties and said, you know what, we actually have additional funding now for infrastructure, early infrastructure funding. So infrastructure is not services, right? This is not funding I can use for a staff, but it's funding I can use to buy a vehicle so that the mobile teams actually can go out. So we are really excited. We engaged the stakeholders really quickly and said, this is the idea we're having. And we submitted it last week. Haven't heard yet, but I'm pretty positive we'll be able to draw down potentially $2 million, $1 million for each, with 2 mobile crisis teams, $1 million for each team, to really be able to build the infrastructure. So that as we continue to develop our action plan, submit it next year, early next year to the state, with watching what's happening at the state, there are discussions at the state level to fund actually the services of a mobile crisis team. So we would get the infrastructure hopefully already up and running. That'll take some time to purchase this equipment. Then next year, be able to know how we can actually fund this and implement it. So this is a very exciting process, which I think in the end can really benefit all of us very, very nicely. Finally, we have another planning grant, which feeds into kind of what we touched upon earlier, which is really the Continuum Infrastructure Program Planning Grant for us to be able to look at. So what is the treatment infrastructure that we have in our county and where are our gaps? So potentially crisis residential, potentially an MHRC, potentially permanent supportive housing, which could be that other level of if somebody doesn't have a home, really truly, even if they stabilize, maybe they can be in the permanent supportive housing situation, right? Doesn't have to be an MHRC. So these are the things that we are able to look at through these planning grants. Next slide. Really quick, we have been able to bring a new provider into the community, Compassion Pathways. They are operating that social rehab facility, 6 beds that I mentioned earlier, right in Diamond Springs. They also have a place in Roseville and a place in Sacramento that we are utilizing. I mentioned we are looking at that mental rehab center in Auburn to bring into our system of care. And with that, I'm going to end right here.
Thank you, Nicole. Would you just mention the IDEA consultant or
Sure.
ongoing services there? Because I think it's important to know we're not doing this on our own. We're
Nope.
really using
Nope.
top-notch resources to try to understand
Thank
what
you.
other counties are doing, how we get the best practices.
Yep. So I was blessed just by the fortune being able to come into the county in my position as the director at the same time when the county had decided to bring a consultant, an outside consultant to evaluate the behavior health division. This is IDA Consulting, Nancy Callahan out of Davis, who has been in the California behavior health world for decades, has really supports right now several other counties with her consulting expertise. And so she launched into a in-depth analysis of our system through that process, and I partnered with her. She had over 50 engaged in interviews with partners, staff. And so I was able to, as I came into the county, to really understand the strengths of the system, the gaps of our system. And so from that, one of the analysis and the recommendations is to look at, you need your entire spectrum of care, absolutely. You need that high level, you need the MHRCs and the IMTs, but where you're really lacking is look at that middle range of services whenever appropriate, build that in the county, outpatient treatment services, build your supportive housing, lower level of care that give the 24/7 setting for individuals, but stabilize people in the community as much as you can, because that will really strengthen your system going forward. Because we don't want to be in a system that focuses only on those high cost, high end services. You know, a good system has the whole spectrum, but really in the middle has the ability to really bring people to the community and build the skill set for individuals as much as possible. Always knowing that we will have individuals that need our services, high level services, for much of their life.
I guess we should ask you to walk through the roadmap real quick too, because we'll probably get questions on that, and then we'll turn it open for questions. So
Sure.
I think you brought it up there, so.
Yeah, so your last attachment is the, oh yeah, right, it's right there. So just, I think important to know numbers. That is our access line right there. So that's the number anybody wants to call. And you don't have to make that determination. Oh, am I going to be needing services from the county or maybe the community health center? Call the access line. They'll walk you through what the right resource is for you. Our
Yes,
wellness,
Nicole is slinging her bullshit. So anyway.
was that a comment? Okay. And so the other numbers are, I think, important numbers to know. Both our systems, substance use and mental health, have to have somebody that's a neutral person. So if somebody feels like in our system, maybe I didn't get the right treatment, I don't like it, but I don't want to talk to my provider. So you also have here the mental health patients' rights advocate number. That's that entity to call. Same thing on the substance use side, the problem resolution coordinator. And I also listed just a 1-800 disaster distress helpline, because unfortunately, I think that's something that all of us sometimes nowadays experience. So that's a federal resource. That's not us operating that. And certainly 988. That's important for everybody to know. 988 if you're struggling.
Very good. So with that, questions, Jenna?
Just wanted to know a little more about the wellness center, who staffs it and how you have volunteers or how it works.
We do have volunteers right now, and that's sort of a part of our system of individuals that feel at this point they're ready to be a lead in any of the groups. It is staffed to our county staff, so they're hired through the county, and they're part of my behavioral health division. The long-term vision is that we actually will be able to build something that is now a statewide effort, is what's called peer certification. So these are individuals that have lived experience. They don't necessarily have to be in my county system, but they have lived experience. There's a certification process now that the state has established. And so they would go through some continued education type training, and then they become certified. And then we would be able to also employ them in our system, and wellness centers would be a great place for that. We're not quite ready yet. There's some steps we need to take to go, but that's definitely a goal for us within the next year by 2023 to have that in place.
Pat, do you have a question? Anyone else have a question or comment? Okay.
How is the conservatorship program used here? My experience is in Central California, and their conservatorship program was overwhelmed. They just had no more room to oversee the patients who needed to be put into conservatorship.
In terms of overwhelm, it's a huge number. I believe right now we have about 60 individuals that are on LPS conservatorship, and we have a staff of 5 deputy public guardians. Now, keep in mind though, and that's why I personally actually enjoy having the public guardian in my division. It's not typical in California counties, but many of those, all of them in some form or fashion, are really part of my specialty mental health services system. So close collaboration. And I certainly, we've worked on that over the last couple of years, and I believe that we've got a good place of feeling that both teams feel there's a collaboration there. So that helps a little bit. It's not typical for counties. Oftentimes public guardian are somewhere else within the county.
Another question, when you're putting these mobile vans together, do you envision at this point making the driver a caregiver as well?
We've talked about that. So likely what we're looking at, and that's still somewhere where I need to monitor how the state is defining that reimbursement. What are their requirements, right? Because you probably are familiar with that. Medical regulations then have certain requirements. Obviously, very easy to understand. Therapy can only be provided by somebody who is either a licensed clinician or what was discussed earlier, an ACSW and associates under supervision of a licensed clinician. Psychologists are also qualified. So that's, I have to watch and see, because the discussion is, do we always need to have a clinician right there on site? Can we have very skilled mental health workers, crisis counselors, plus peers that are very skilled and trained and know and have been in the shoes of the individual? And so potentially we could think about having let's say a clinical staff, maybe a clinician, maybe a mental health worker, and 2 peers, maybe a peer, maybe a family advocate, One of them could function as the driver and the other one, but then on the scene, we would be able to address both the individual, but oftentimes, obviously, there's people around that individual. And so that second staff can also engage with whoever that is, that support person, that family member that needs some attention too, because the crisis is involving them, right? Impacting them emotionally. So likely not to have a driver all by itself, but likely be able to have staffing and then have enough staffing that somebody is a driver during that driving time and others are able to address the individual. Mhm.
Self-harm would happen to an ER or something.
Right, right. So clearly these are scenarios that if we have somebody who's a potential of danger to others, that may be the scenario. So you heard us talk about, do we always have a law enforcement at the scene right from the beginning? Or do we think about a model where there might be situations where we could have the clinical team go out first, but always knowing that the law enforcement partners will be there if they need to be called on the scene, right? So we would need to make that determination. There will be situations where my team, because the van would not have any separation, would not be able to ensure that if the individual who is still so actively presenting with danger to others wouldn't become a danger to whoever is transporting them, right? So really, in the end, I envision a system that gives us the best triage protocols as possible to be able to address the situation the way it presents itself. Sure, sure. Right. So I think, again, what you will find is that we will have statistics for our systems. So the community health center would have, data for who they serve and how many and how frequently. And my system would be able to show that data. But keep in mind, for the mental health, right, my data really shows for that high level of presentation for the people that qualify for the specialty mental health services. I am not aware that we yet have had anywhere where we put those statistics together. Terry, do you? Oh, well, Dorado, thank you. Yep. Duly noted. Yeah, no, absolutely. Yeah.
The 3-year plan for the MHSA is where a lot of that outreach and data needs to be collected. That'll be starting, as Nicole mentioned, very soon. So if you really have an active interest in that, I would suggest you get involved with that early inputs from the public. Because the Behavioral Health Commission will be discussing it, but the more community inputs we get, the better we can define what those needs are. Statistics are one thing, the needs are always changing, right? So that would be, I think, the opportunity to really engage and get involved with that detail.
So we have some data that we're reporting, not all of the points that you're addressing, but join us or look at the Behavioral Health Commission website when we post, because every month there's a director's report posted there that has some data. Not all of that, but some of it already, so. Yeah.
Other questions or comments? Nicole? I just have one thing to remind people of is we have hired a new Director of Health and Human Services. Evelyn Schaefer by name, and she will be joining us. I think her effective start date is September 24th, which is Saturday. So I think we're expecting to see her on the county campus on September 26th, i.e. a week from today. So I think that's encouraging, and I know Dr. Clavier and I have had discussions about once she is on board and settled, we need to have a discussion about a number of different things in terms of her thoughts on some of the things going on now. What is the progression with MHSA, schedule and stuff? She's bringing a new set of experiences to us. And I think it's important to tap into that and get your inputs on things. We've got a lot going on with homeless sheltering, the navigation center. She's going to have to be briefed on a lot of those things as well because she's stepping into a role that's got a lot of things, very active and somewhat volatile from that perspective. So we're really pleased that she was available to come join us. She comes from the Houston area, which was her most recent place of occupancy, but she's had a lot of different experiences in different places. So I think we're all looking forward to that.
Very
And it gives us another dimension in terms of better understanding how the organization develops and what we can do to improve the delivery of services in the future. So just one more resource. So with that, I'm going to say thank you again, Nicole. And obviously we're going to put all of the slides and the information out via our email notification on the meeting minutes, so you'll have access to all the details. I recognize some of the slides are kind of tough to read from back there, but when you get that email, you'll be able to see it and record the numbers if you want and follow up from there. So with that, I'm going to segue to our last session, given the hour. We're almost at 7 o'clock, but I think we're doing pretty good. And so I would like to invite Frank Porter and Diana Rabinowitz. Pardon? Oh, and Jen Melnick. Okay, so the three of you. Did we get that down? Okay. Okay, no, that's okay. So great. Didn't realize Jan was going to present, so that's good. It's probably better if you come up here because the way the camera's facing, then if people see your back as opposed to your face. If you don't mind coming up and joining us.
Oh, it says.
We'll go ahead and get this started because I think this is another very interesting and active proposal to the community. And I'm certainly hoping that it advances with a reasonable success rate. And a lot of that ends up being fundraising and getting everybody on board and finding a site and all of that. It's always a challenge, but I think the group that's been assembled is certainly up to that. They have a lot of experience. So who wants to start? Wasn't sure.
Okay. So I researched the clubhouse concept. Clubhouse
Now, give a little bit about your
I will.
background.
Because my son has serious mental illness, and right now he's in a locked facility, one at the MHRC. And I see recovery is possible. I believe recovery is possible. And so, you know, when I first moved here a couple of years ago, I started going to support groups, NAMI support groups, National Alliance on Mental Illness support groups. And one of the things I kept hearing was from the parents that were showing up was that their kid is in the basement, that maybe they're on medication, maybe they're not, but they're kind of languishing, they don't have friends, their lives are lost. And I don't want that for my son. And I know also that it's a potential powder keg because you're in that situation and frustrations can build, and then, you know, before you know it, the person is acting out and escalation is happening. And so I had heard about the clubhouse model started in New York City, and it was actually 5 or 6 people who had just exited a mental hospital, and they would get together and they formulated this, you know, their coalition, and they started developing a club where they had to cook meals for each other or together, and they looked out for each other. And over the years, it's 20 or 30 years, it's developed into an international 320 clubhouse model all over the world. And so by now, so then I spoke with other people in the county about gaps that exist in the mental health continuum of care, and sent out, here's the website, have a look, what do you think? And we formed a team.
And my interest is that my name's Frank Porter. I'm a longtime resident of the county. I've gotten in my retirement. One of my projects is homeless services and also affordable housing. So I've been in the founding of Housing El Dorado. Some of you may have heard of Housing El Dorado. As you well know, the homeless population in our county, about roughly, according to the PIT count, about 42%. Some people 40 to 46% seems to be the range if you look at counties around the state, of the homeless have mental health issues as either a cause or an effect or some, part of their diagnosis or their situation. And we also know from studies that we've done on homelessness that people are teetering into homelessness. There is a huge population in our county. People don't appreciate how probably another 40% of our population are one paycheck away from being homeless. Or have one calamity, financial calamity away from being homeless. A lot of them are teetering, and as rents go up, that becomes more chronic. So how do you help prevent homelessness, and how do you help treat it? And housing is a part of that, but you also have to have programs, a spectrum, as Nicole said, of programs. And many of them are in the mild to moderate range, effective, scalable models that work and been proven. And this Clubhouse International model, we've done a lot of research on it, is worldwide. It is a well-proven, well-tested program. It has been validated through lots of research. It is cost-effective. It works around empowering people, and also a workday calendar. We'll talk a little about that if we have time, and what that looks like, and how it works to pull people into having a sense of belonging in this community called the Clubhouse. So I'm very excited about it. It's one of the projects I got pulled into.
I'm Jan Melnico. I've been involved with mental health services in this county for about 15 years when my daughter became ill. And I met Diane at a support group meeting when she came to El Dorado County, and she had me when she started talking about the clubhouse thing, because what I realized after all these years is, you have the medical piece, which is the psychiatrists and the hospital and all that. You have the psychologists and the counselors and so on, and that's another piece. But what folks really need for their day-to-day lives is that social piece. And watching my daughter go through her struggles, I realized this was something that was just really important. We all need friends. We all need people in our lives. We all need places to go, and we all need a purpose. And this is what we look at when we look at a clubhouse. And I have also spent about the last almost 15 years helping at the Wellness Center, doing an art class. And so we sit around that table. We don't talk about mental health. We talk about politics. We talk about the latest movie. We talk about whatever is on their minds. I've watched romances bloom. I've watched people get jobs, lose jobs. All of these things, these are just people needing interaction. And so the Wellness Center is this lovely little place, but we need something much, much bigger and more encompassing in the county to provide this.
Yeah.
So pretty much as has been described, psychosocial rehabilitation. So once a person has achieved a level of stability at the Wellness Center through County Behavioral Health, then they're ready for the next phase of their recovery, which it involves the social, the emotional, what if they lost their education, if their education was interrupted when they first got sick, or if they lost their job or their career plans. A clubhouse is a place for them to reclaim this in a mutually supportive environment. As Frank mentioned, the Clubhouse El Dorado is based on Clubhouse International models and standards. It's validated, proven, and it's a successful program. Next slide. Our vision, the Clubhouse El Dorado, located in El Dorado County, working community for people experiencing mental health challenges. And this is a big vision, and it is developed in so many other places and is so productive and so worthwhile in other areas. We've had 2 visits down to one clubhouse so far. The group has, and everybody comes away with a wonderful sense of possibility, you know, it brings a lot of hope. Okay, go ahead next, please. Yeah.
We didn't rehearse this. We put the thing together, we haven't rehearsed it.
Yeah.
But basically, I'm not going to go through all this data, but, you know, we, in our county, we have, those are the numbers on how many people are estimated to need treatment and have mental health issues in our county. And you can see those are substantial numbers, and you can see Nicole and Terry and all the other providers who are working so hard to provide treatment and provide parts of the continuum of care are struggling to keep up with it. And so what's another piece of this that could scale up and handle even more and get in that middle area, mild to moderate, where people are either teetering into have pre-existing mental health conditions that are mild, that are going to get worse if we don't have some place for them to get support, or ones that have come out of treatment and could benefit from having ongoing social, psychological support services.
So back up just a second. The one that really stood out to me, just to be real, is this one right here. 70% of youth in the juvenile justice system have a mental health condition. Why do you think we have a juvenile situation that's growing? Our probation department and other groups are working so hard to try to change, because we're not getting this in early intervention. We're not doing the prevention and early intervention with the youth that we should be doing. If you recognize there's an issue and you get the proper treatment. So to me, that's a leader for a lot of those things. If you can start working the problem on the front end, you're going to have really great results on the back end.
And that's why I'm so delighted to see Nicole's, you know, the work that she's doing with County Office of Ed, and I think it's just brilliant. It's exactly where we're going to go. And the other thing is, I don't get into these. Well, we should do this, this, and this first. Honestly, we need to do all of these things concurrently, don't we? I mean, if we could, we'd try and do as much as we can with the bandwidth and resources we have. But how do you get a better bang out of your dollars? And I believe the clubhouse is a key part of this that could help us. Go ahead. Next slide.
Yeah, I referred to this briefly. Education interrupted, work career plans interrupted. And relationships damaged and lost, obstacles to obtaining effective treatment, the wait times, or even just, you know, I go to my therapist once every 2 weeks. What am I going to do in the meantime? You know, if I feel I can't work, if I'm afraid to go to school, I need someplace to go where I can get that kind of support that I need. So that's what we're hoping, that the clubhouse can be this kind of constructive outlet where people can go and engage with each other and with their dreams, reclaim their dreams, reclaim relationships, reclaim emotional health and social health. Go ahead next.
And you can see our startup team has grown. There were 5 of us. There are now, I've lost count, 15 now on our startup team. And you can see we have support from the probation department is very, very eager. They see how this fits into their work, because their clients would benefit from that. The Department of Rehabilitation, the regional staff, we've connected with them. They've attended a couple of our meetings. They went and did a tour with us. They see how this fits in with the clubhouse fits in with their work. And you can see Placer Independent Resource Services has an office in Placerville. Their services really complement what we're talking about doing. And we're actually, one of those sites we're looking at, we would co-locate with them in an office building where they're currently at, and we would have our clubhouse, our startup clubhouse, in an adjacent rental lease space. And the two things would complement each other. We're looking at those opportunities for integration. Next slide.
How is a clubhouse structured? It's what we call a work order day, where daily activities are organized around a structured schedule. So they come in, there's a board which tells you what's going on that day, and they can choose what they want to be involved in. And it generally follows a typical 8-hour work day, so they get into that particular pattern. And we have members and staff working side by side. Many more members than staff, because the idea is to get the members involved and taking ownership. So the member volunteers do as much or as little as they do, depending on where they are in their particular frame of mind. These are episodic illnesses, so you have bad days, you have good. So these are different types of activities that one member can sign up for their day. There's food prep, administration, public relations. They do outreach. So if they haven't seen somebody for a few days, they'll get on the phone, call them, sometimes visit. If somebody relapses, goes back into the hospital, several of them will go and visit. So the idea is to sort of bring them back into the circle of care. And as I mentioned before, resuming education, help with accessing community support services, and just planning what activities they want to do. They have field trips, they have, parties, a lot of parties, there's a lot of celebration and, incredible joy that we've seen. They do artwork, they do media work. I mean, they're really active. There's a lot of opportunity for growth there. Go ahead, next.
The other big focus is supported employment. And so there's a whole program. You partner with local businesses to place some of the clients who are ready to take on work part-time initially. And there's 3 levels of work support that is provided to the club members. They don't have to go to work, but the goal is to give them purpose. And as you well know, work is often a sense of purpose. And they haven't experienced that sense of being efficacy that they get from going to work. So there's a supported employment model where the client goes out, or one of the members goes out to a work site, and there's a mentor coach that goes with them. There's a lot of feedback and support for the employer, because we want the employer to have a successful experience, obviously. And then there's a transitional stage where you start pulling back, and then eventually they're independent. And the goal is here to have them back into the workforce or into school, and if we can, and if they're ready for that. So there's a lot of support for that. And the employment, as it says, is always at the employer's place of business, and it pays the prevailing wage for the required work. So we are getting them back into actually receiving a paycheck. Excellent.
So one of the things that we had 3 people from the Department of Rehabilitation join our meetings and visit. And one of the things they stated was that the supports of the work order day it's that missing link that they sometimes get people at the Department of Rehabilitation. They'd like to place them, but they might not be ready, or they try and it doesn't work. And that's, so they feel that this is a nice stepping stone that helps prepare them for the next step, which would be independent employment.
Right, so some of the activities at the club are preparing a meal. They are preparing an event. That we organize fundraising events. The members do that. And that's employment at the club itself. And then there's outside employment with employers. Next slide.
What have we accomplished so far? So we've had 2-day startup training with Clubhouse, and we've had 2 visits to the Mentor Clubhouse. We've explored potential locations, and one that Frank mentioned is located near one of our partners at the Placer Independent Resource Services. We've got a draft budget and identified 2 potential program directors. The program director is really an important piece on it. So that will be looking for the right person. It'll be a job. So when you think about El Dorado County, you're not thinking, oh, don't worry, you'll be able to find somebody with Clubhouse experience. But we're really fortunate that 2 people have been referred to us who know about what we're trying to do and are excited about collaborating.
One of them lives in Carmichael, the other one in Auburn. And so they're very interested. They are not currently working in clubhouses, but they've done it in the past. They're very enthused about the idea that one is in development over here. Next. There's our to-do list, and I won't go over that, but that's right now we are all volunteers. A couple several of the people you saw in our startup group are obviously work full-time. Diane and I we're the retired consulting team that's working for water and coffee. But that's some the work that we're doing, and I won't go any further. Right now, we are looking at forming ourselves under the umbrella of NAMI, the El Dorado chapter of NAMI. We may, in fact, get to a certain point where they may want us to be a separate entity. We'll get to be decided. Those are all things to work out. Next slide.
So how can you help? Help us build a thriving community organization. We would love to have the opportunity to speak to meetings. So if you have an organization that would like to hear about the clubhouse, we will accept an invitation. We certainly would like people to join the group and offer further to members. We join our startup group and board. You have the ability to donate funds or supplies as we move along on this project. And again, networking is key. Yes, that's it. Okay, if you have a copy of this slideshow and you think about it, you'd like to do one of those things, offer an opportunity to speak, or you know of business who would be interested in hiring members eventually, or you know of a way to access supplies that we might need eventually, or funding, get in touch.
And we have a brochure, which I will hand out.
Okay, very good. Well, Frank is handing out the brochure. Questions or comments? Back to panel of three here. Yeah, Veronica. Yes, please.
Just comment, it's an excellent idea. And it's an excellent idea. I think it'd be very beneficial to the residents of El Dorado County. But two things, one thing I noticed, that on your advisory board, for lack of a better word, if you're interested in engaging the business community, then you might want to talk to the local chambers of commerces, and then also reach out to Seroptimus and any of the business, Lions Clubs and any of those organizations that have other members, extended family members that may want to engage outside of offering jobs and internships for the members, but also have family members that they want to be invested on an emotionally level to be tied to. The other thing too that I noticed when, is it Nicole? Yeah, when Nicole was talking about her program and about the grants that you're submitting to the state, having been a person that has worked for the state on the legislative side, what they're going to be looking at, as you know, is collaboration, but not only with other state or local city or county agencies, but the general public. And so this could be the fundraising arm that could help to be able to say that we have some leverage of accountability and partnership, because that's what they're going to be, how much of the community is truly engaged with what you're doing. And so I just wanted to comment on that. Also, Contra Costa is excellent in terms of services. Santa Rosa is another one that I would highly recommend that you connect with in terms of services in mental health.
Just to respond to that, Contra Costa has gone in the direction of Clubhouse in a big way. The county mental health services are using Clubhouse as a component in their mental health delivery system. San Diego County, in a huge way, has also, I think they have several different clubhouses down there. One of the building blocks.
Another comment that comes to mind is, so I'm assuming then that individuals that are engaged in becoming members of the clubhouse have already accepted the fact that they have mental health issues. So there's no issue there at the stigma, because your location is going to be significant in drawing people to come. And if you're going to align yourself already with a county agency, then that would prevent somebody from coming, especially a young person, to come to a quote unquote clubhouse. So you might want to consider that when you're dealing with youth. I mean, they're already having an issue already, but to identify with having a mental health issue is really huge. And that's really something to consider in terms of expecting them to come. That takes a level of maturity.
That's definitely a challenging piece, and it narrows who's going to come to the clubhouse, because one of the requirements is they have to have like a doctor's note that they have a diagnosis or that they're in treatment of some kind. So, yeah.
I'm curious if you have ever come across any court-ordered attendance at a clubhouse, and how you will be working with juvenile probation to determine whether those students will be integrated into the clubhouse activities based on their school requirements. And also, one further question is, have you thought anything about how the care courts would be coordinated with your clubhouse routines and requirements?
Two enormous questions. The first one, I can say that I think there's an age that you have to be 18 or older. So we would not have high school kids coming. We hope that there'll be NAMI on campus and the wellness centers in the high school to deal with like prevention or early detection issues and provide support there. But once a person is 18 and they've been in treatment, of course, and they're welcome to come. Now, regarding the probation department, court-ordered attendance is not a part of what Clubhouse is. It's all, you choose to come. But I would imagine that a person who's in the probation system, if they're given options, well, you can do this, you can do this, you can do, they might find coming to the clubhouse appealing, and they might want to come. But that it's not like the standards prohibit mandated attendance. So, and when I say the standards, I'm talking about the International Clubhouse has 39 standards by which you qualify for affiliation. So, and you get the supports from them.
Right, and as a former school superintendent, I can say they also require certification on those standards, and they also do periodic rechecking of you abiding by those standards. So what I like about this program is that it's been validated, it's been vetted, it's been practiced in multiple settings, and it also requires clear certification around some clear standards about how you conduct the program, how it's operated, and so on. So over time, it sustains it at that quality level.
And regarding care court, I think that's more of something the state is trying to set up to help get people into care. So anyone can propose that a person gets conserved, or there's a kind of a modified form of conservatorship to support people to get the kind of treatment that they need. Sometimes a person who doesn't believe they're ill, they need a little prodding. Sometimes it works and sometimes it takes a little longer. But once a person is in that care, then of course they can come to the clubhouse if they choose.
The CARES Court comment is germane because we're just now starting to learn about what the details of it are in the county. We're starting to write the information that will flow down to the county, the funding is going to flow down to the county, how it's going to be implemented, what the judicial system involvement is, what the county's requirements or obligations are. All that's just starting to now get sorted out. So my expectation is we'll probably have a Board of Supervisors presentation in probably the first part of next year to really fully describe that once we've had a chance to really digest it and understand in El Dorado County, how is this going to work? Who's going to do what and when? And what volume of clients are we looking at going through the CARES Court? It's been estimated at a fairly low number, like 20% of the mental health population was the number that I'd heard estimated. I'm not sure if that's realistic or not. So there's a lot of variables right now. We're still trying to get our arms around it to determine what are all of the pieces of the puzzle that are supposedly going to work together. But the good news from the county's perspective is through petitioning, through lobbying, that sort of thing, you got the state to agree that monies need to be provided to the county. It's something the county just can't take on without any new funding. So that remains to be seen how much we get. because it's a pool that was put together for all the counties, and I don't know how they're gonna allocate it, break it up. But more to come on that, so we'll try to keep the public informed as we go forward and have a, a presentation made to the Board of Supervisors in all likelihood, make sure everybody gets notified of that particular activity. Good questions. Trudy?
My question was just about self-referral, and you kind of answered that. They need to have some kind of referral from a professional.
Oh, yeah, Steve, please.
John, I'd like to follow up on your comments about the presentation to the county. I think one of the central arguments could be made is having a clubhouse in El Dorado County would save the county, save the behavioral health department unbelievable amounts of money, because it would prevent people from recirculating back in the system over and over and over again. And I think that would perhaps be one of the strongest arguments we could make. That's it.
Yeah, good point. No, I believe that's true. I'm not sure that there's statistics on that in terms of, okay. So we can look at the statistics too, because it's a given, it's going to help. The degree of is something I can't estimate, but.
Well, and, like I was pointing out earlier, they one day to the next focus with mental health issues, it gets more severe or it doesn't get more severe. And how do you sustain them so that they're not bouncing back and forth between this program and that program constantly? And I think Steve makes a great point. From a cost-effective standpoint, the research says this is a good investment.
Okay, so I think I'm going to bring this to a close. Oh,
All right, I
sorry.
just have one more comment.
Yeah, Robin.
I was actually went on the trip with you guys in the van out to the clubhouse, and I really liked it. I think another component that I haven't heard mentioned is it is, if I'm correct, patient-driven, peer support-driven. And it's not, it had a nice flavor of not traditional Western medicine. It's not like doctors aren't there. I didn't even see therapists. I was like, am I going to be out of a job if we end up this? Because
Don't worry about that.
Don't
ever worry.
I know. It's just like saying. But, it's also very multicultural. Our resources for jobs. So to really, other than, I like the residential because of community, and I like this because of community. And that reduces isolation, which is really huge in mental health. One of the reasons they're spiraling down is because mental health brings the stigma, very big sense of isolation. Also the stigma, you don't worry so much about the consumers having the stigma to go to their clubhouse, but the community needs to be educated. So, communities are one doing the judging of people coming in, right? Yeah. So I just like to advocate for it. I think it's a really good model. I think like Hawaii, I think it's their state model in Hawaii. It's just a very human way of dealing with community and mental health and norms and accepted ways of behavior. So it's a good thing.
Absolutely. And with respect to the outreach, I don't know if you've had a chance to think about the faith-based communities, because I think they're huge in terms of seeing their parishioners struggle. And I got connected with a family at our church that I referred to NAMI because they were having problems with the God. But it's that socialization atmosphere where people talk about things that helps grow the momentum. So I know the Foothill Interfaith collaboration would probably welcome an opportunity to bring that forward to that particular group of interfaith participants and stuff. Because I think, again, that's a major part of our communities is that faith-based piece of it. And I think you'll find you get a lot of support there, as well as the Rotary and Lions Club and all the other good organizations we have in this county. So, all right. So I want to thank all of our presenters, all of our participants. I think this has been another great session. And I will remind everybody that we will send out minutes that will have the links to all of the detailed information. If you have additional comments or questions, either send those to the presenters directly. I guess they don't have the direct contact information, right? So better to send them to our office and we'll direct them to the right people is probably the easiest thing to do. because we do want to make sure that this is not just the end, but it's the beginning of the follow-on activity. There's a lot of things happening. I think this was very educational, informative for our community. We want to support all those things we can possibly support. But at this point, I don't anticipate another forum because I think we've done our work to try to educate, inform, get people going with things. And now it's everybody's responsibility present to share that information, right? Get them connected with the organization you think they would be willing to work with, either the service part of it, the volunteer part of it, the membership part of it, whatever it is, because I think that's our obligation at this point is to carry that forward. So with that, any final go backs? Anybody? All right, very good. Thank you again. Really appreciate the participation and onward.
Appreciate all the presentations. Thank you so much. You stayed a long time for us.
Very good. Yeah. Well, the work went out to all the people who participated. We just kind of